According to the American Heart Association, about 5 million Americans are diagnosed with valvular heart disease each year. Valves on the low-pressure right side of the heart rarely cause symptoms, but the left-sided valves often need to be repaired or replaced. The aortic valve is the most common valve to be replaced, and the mitral valve is the most common valve to be repaired. Cardiac valves control the flow of blood through the heart, ensuring that blood moves forward and there is no backward flow of blood. The valves open and close in response to pressure changes caused by the blood flow through the four chambers. There are 4 valves of the heart situated between each chamber. The semilunar ones are on top, like the moon is the highest, and they are the aortic and pulmonic. The valves that are below them are the ones between the atrium and the ventricles and are called the AV valves, or the tricuspid and the mitral, which is also called the bicuspid. It is the only one that has 2 cusps instead of 3. This diagram shows where we auscultate to hear the valves close, but also shows where the valves are anatomically. Remember that the mitral valve is at the 5th intercostal space mid-clavicular line, slightly medially. Also that it is at the apex of the heart, and knowing this will help you in answering some of the test questions. The heart valves consist of leaflets or cusps which are pushed open to allow blood flow and which then close together to seal and prevent backflow. Each valve has 3 cusps except for the mitral valve, which only has 2, and that's again why it's called the bicuspid. Blood moves within the heart during diastole as it enters the right atrium from the inferior and superior vena cava. The AV valves are open as the atriums contract, moving atrial blood into the ventricles. As the pressures increase in the ventricles, the semilunar valves pop open and the AV valves snap shut as ventricular systole moves the blood outside of the heart. The right ventricle blood moves into the pulmonary circulation and the blood of the left heart into the systemic circulation. As the pressures subside, the semilunar valve snaps shut to stop any backflow of blood, and the AV valves open again. S1 and S2 are heard only during ventricular systole. S1 at the beginning of ventricular systole as the AV valves snap shut, and S2 as the semilunar valves snap shut, signifying the end of ventricular systole. Notice that the right and left heart contracts from the bottom half together and then from the top half together. Diseased valves can occur either as a congenital heart defect or as an acquired heart valve disorder. Rheumatic fever is the major cause of mitral stenosis or prolapse. Other causes are infective endocarditis, severe calcification of the valve opening, tumors, systemic lupus erythematosus, or different cancers. Blood flow can be affected when heart valves do not open or close properly. Regurgitation occurs when the valves don't close completely, and stenosis occurs when valves don't open fully. In both cases, forward blood flow is reduced, although more so with the stenosis. And in both cases, the antechamber receives more blood than it was designed to receive. That backflow of blood can lead to hypertrophy and muscle weakening. A stenotic valve forces blood to back up into the adjacent heart chamber, while an incompetent valve allows blood to leak back into the chamber it previously exited. To compensate for poor pumping action, the heart muscle enlarges and thickens, thereby losing elasticity and efficiency. In addition, in some cases, blood pooling in the chambers of the heart has a greater tendency to clot, increasing the risk of strokes or pulmonary embolism. Prolapse only occurs with the mitral valve, which is the only valve with 2 cusps. The loose leaflets balloon backward into the left atrium during systole, which may or may not result in regurg, depending on the severity. These abnormalities result in extra heart sounds, such as murmurs and clicks. Our 4 valves normally close at exactly the same time in pairs. The semilunar open and close together, and the AV valves open and close together, creating the normal lub-dub sounds that we hear. When one valve is diseased or slower to close, an extra sound can be auscultated. This sound is referred to as an S3 or an S4 click. Murmurs are different. They are sounds created by turbulent blood flow due to either valvular regurg or valvular stenosis. Murmurs are graded according to how loud they are to hear. It's on a scale from 1 to 6, 1 being so faint that you can barely hear it, and 6 being so loud that you could hear it with your stethoscope off of the patient's chest. In the chest wall, you can feel a vibration, which is called a thrill. Clicks or extra heart sounds such as S3 may be associated with heart failure, but they can also be normal in childhood. S3 sounds like Kentucky, Kentucky, Kentucky when you're listening with your stethoscope. S4 can indicate left ventricular hypertrophy and is usually pathological. The sound that you will hear with an S4 is like Tennessee, Tennessee, Tennessee. They are both 3 sounds, but the accent is different. If a patient has an S3 and S4 together, the sound auscultated is referred to as a gallop. The sound it makes is like hello, goodbye, which is 4 separate sounds. Mitral valve prolapse has a different extra sound, which is a mid-systolic click. This occurs not so much from the incompetent closure of the valve itself, but from the abrupt halting of the blood flow caused by the chordae tendineae. Artificial heart valves also have a different sound that is referred to as a click. Mitral valve prolapse is the most common form of valvular disease, affecting about 6% of all women. It is associated with connective tissue disorders such as Marfan syndrome. Blood may back up into the left atrium or it may not, and most people have no regurgitation and are asymptomatic as the valves still form a tight enough seal. Those with regurgitation or symptoms most often experience fatigue, shortness of breath, dyspnea and syncope, palpitations, chest pain, and anxiety. Teaching revolves around helping them to take their medications and teaching them to reduce their intake of any stimulants like caffeine or ephedrine products, and also reduce alcohol consumption. Mitral valve stenosis reduces the blood flowing into the left ventricle and backs it up into the left atrium and the lungs. Depending on the severity, increased pulmonary congestion leads to shortness of breath, dyspnea, exertional dyspnea, paroxysmal nocturnal dyspnea, and orthopnea. The increased blood in the left atrium causes the heart to have to contract harder and faster, requiring more O2, which increases damage to the heart. It also causes tissue hypertrophy, which weakens the heart muscle and leads to conduction disturbances. This is all due to the retrograde damage. Damage also occurs because of the decrease in cardiac output. With less blood moving forward through the aorta, perfusion to the coronary arteries, brain, and the systemic tissues is also reduced. With a decreased cardiac output, the RAS system will try to vasoconstrict vessels and throw more blood into the heart by saving fluids, but all of this increases the cardiac and the pulmonary congestion. Severe pulmonary congestion will eventually strain the right ventricle and lead to right ventricular failure also, which is called cor pulmonale. Untreated mitral stenosis can progress from a mild disability to a severe disability in about 3 years with left ventricular heart failure. Ineffective atrial contractions also allow stagnation of blood in the left atrium, which will facilitate the formation of clots and thrombi, increasing the patient's risk for strokes or other distal artery occlusions. Untreated, a patient can progress from asymptomatic to having a severe left ventricle disability in less than 10 years and continue on toward a right ventricle failure as well. Mitral regurg, also called mitral insufficiency, is less severe. Patients with chronic severe mitral regurg may remain asymptomatic for years because the regurgitant volume load is well tolerated as a result of compensatory ventricular and atrial dilation. When symptoms do develop, the most common are dyspnea, fatigue, orthopnea, paroxysmal nocturnal dyspnea, and palpitations caused by atrial fibrillation. The aortic valve can also become incompetent and can result in either regurgitation or stenosis. People with aortic incompetence may not have symptoms for years, but as valve incompetence worsens and forward blood flow is diminished to the coronary arteries and the brain, signs and symptoms would include feeling faint or fainting with exertion, dyspnea, shortness of breath, especially with exertion, fatigue, heart palpitations or sensations of a rapid fluttering heartbeat, heart murmurs, and swollen ankles if the heart weakening effects lead to heart failure. Chest pain, angina, or chest tightness is also a symptom due to the reduced blood flow to the coronary arteries. Resting to reduce oxygen demand will often relieve the chest pain without using nitroglycerin tablets. However, always inform the MD when any patient experiences chest pain, since it is a symptom of ischemia. Diagnostics should be ordered to rule out an active acute MI. Valvular problems are diagnosed by clinical symptoms, but also by an echo or transesophageal echocardiogram. So as a review, low pressure right side valves, the tricuspid and pulmonic, rarely require treatment even when incompetent, but the high pressure left-sided valves, the mitral and the aortic, depending on the severity of incompetence, can result in clinical manifestations of left heart failure and or right heart failure, such as pulmonary congestion, cardiomegaly, and decreased cardiac output. Most people with symptomatic valvular diseases experience varying degrees of left heart failure symptoms. These include respiratory signs and symptoms of pulmonary edema with dyspnea, paroxysmal nocturnal dyspnea, and orthopnea or orthopnea. If there is reduced blood flow to the brain, dizziness and syncope can occur. Chest pain, angina pectoris, occurs with increased oxygen demand on the hypertrophied ventricles and decreased blood flow into the coronary arteries. If it progresses from left heart to right heart, the patient will also experience fatigue, weakness, palpitations, and cough from pulmonary congestion and edema.